The normocytic anemias are characterized by a mean corpuscular volume from 80 to 100. So this is a normal size. This is what they should be. And if you think about this, these fall into two categories. And one is the non-hemolytic. So this is an underproduction. And then the hemolytic, this is due to premature destruction. And if you think about both of these, premature destruction or underproduction, neither of these should have any effect on the size. So it kind of makes sense that both of these would fall under the category of red blood cells, anemias that are of normal size. They're not produced enough or they die too quickly. So the non-hemolytic, where they're underproduced, this is you can characterize this with a low reticulocyte count, which we'll talk about. And then the hemolytic would be a high reticulocyte count. So what are reticulocytes? These are premature red blood cells. And it's kind of like what we saw in the immune module. You had a left shift with neutrophils. If you really, really, really needed a lot of, you needed an army really quickly and you didn't have that many neutrophils, you would start to push out the immature, I bands, which we called a left shift. And I thought of that as like, we're at war and we really need all the men and women we can get. And so, we don't care if they're not 18, we're going to push them out when they're 11. We're just going to give them an assault rifle and say, go get them. It's kind of the same thing here. If you have a hemolytic anemia, all of your red blood cells are being killed. They're being killed. And so your body is, to counteract this, is like saying, okay, we need to just push out as many red blood cells as we can to replenish the ranks. And it gets a little bit overzealous. It pushes them out before they're ready, which is why the reticulocyte count go up. It doesn't go up here because the whole point is that this one is characterized by an underproduction. And there's a variety of reasons for why the red blood cells might be underproduced that we'll get into. So to calculate the reticulocyte value, it should normally be 1% to 2%, but it's actually difficult because this is expressed as like a percentage of the red blood cells. So you kind of switching two variables at once. So if the red blood cells are also down, that could be a confounding variable for your reticulocyte count. So we have a corrected reticulocyte index. And the formula for that is the patient's reticulocyte percentage multiplied by the patient's hematocrit divided by a normal hematocrit. So let's look at an example of this. Let's say the reticulocyte percent might be 5. And we go, oh, wow, that's high. It should be 1 to 2. But we then also note that the hematocrit is particularly low. And so we say, okay, 5% multiplied by the patient's hematocrit divided by the normal hematocrit. 5% times 1/2 is 2.5%. So it's actually not as high as we originally thought once we went ahead and figured out what the corrected reticulocyte index is. All right, so let's start with the non-hemolytic underproduction of red blood cells. A couple different reasons why this might happen. So iron deficiency and anemia of chronic disease. We've really already talked about this, so that'll be quick. But that's a low iron in both cases. We know whether or not you have low iron or whether or not seems like you have low iron because you're hiding it from the monsters. Aplastic anemia means your bone marrow sucks, you're not producing it. And then chronic kidney disease, CKD, means your kidneys suck and they're not producing EPO. Erythropoietin, which is necessary to stimulate red blood cell production in the bone marrow. So whether it's iron deficiency or anemia of chronic disease, we say that early on, so both of these cases, not enough iron to produce heme, and therefore you're going to have less red blood cells. And early on, we said that, okay, we're fine with just less red blood cells, but at least we'll equip them with a normal amount of hemoglobin, and that's why they're normocytic. However, eventually we say, okay, we're going to have less red blood cells, but we're also going to have less hemoglobin per red blood cell as well. So that's why they fall into both camps. All right, so let's move on to the new stuff. Kidneys make erythropoietin, stimulates erythropoiesis. So this would be normal. And if you're hypoxic, you're up in the mountains, you're not getting enough oxygen, your kidneys will produce more EPO so that your bone marrow will produce more red blood cells so that you can deliver more oxygen to your body. And obviously, blood doping and many athletes have taken EPO to gain a competitive advantage. But if your kidneys suck, then you can't produce it. All right, moving on to the next one. It's short and sweet. Aplastic anemia, aplasia, no proliferation. In this case, because you're defective stem cells in your bone marrow. And then anemia, of course, maybe I didn't explicitly say this, maybe I did. Anemia is a lack of red blood cells, but this is a misnomer because, at least in the case of aplastic anemia, the bone marrow doesn't just make red blood cells. It makes white blood cells. It makes platelets. So it's going to affect everything, which is why this is a pancytopenia. And if we want to think about what the symptoms are, just think about what would happen. If you don't have anemia, you have pallor and fatigue, and apparently pica. You just start eating paper thinking it's potato chips. And leukopenia, no neutrophils, means you're going to be more prone to infections. And then no platelets means you're going to have more bleeding. Your clotting is not going to work as effectively. And this is just a picture of normal. We have all of these fun platelets and white blood cells and red blood cells. And here's a little bit less of everything. The bone marrow is particularly fatty. There's less hematopoietic stem cells has been replaced with fat. All right, so what can cause this? They used to call it idiopathic, but now they actually think that it might be an autoimmune T-cell response, often following hepatitis. It could be genetic, so Fanconi's syndrome is something you'll see a lot in the renal section. It has to do with kidneys. People have malformed thumbs is something to look out for, but you have defective DNA repair enzymes. So this could lead to cancer as well, but in this case, we'll just say that defective bone marrow causes aplastic anemia. Different viruses, Epstein-Barr virus, hepatitis, HIV, parvovirus, B19, which we'll come to, benzene, I think shoe factories, rubber factories, radiation, maybe you work at a power plant. Maybe you work dealing with the waste of a power plant, or maybe you had a cancer and you had someone give you radiation therapy. That could eradicate all of these stem cells in your bone marrow. And then many medical drugs, cancer chemotherapies, immunosuppressants, even thyroid medications can go ahead and wipe out your bone marrow, causing aplastic anemia. So the treatment, this mostly works for the idiopathic immune-related, but anti-thymocyte globulin targets the T cells, and then the immunosuppressant. But then you could just give somebody transfusions. Again, whenever you have transfusions, you should be aware of getting in more iron than your body than you can excrete. Again, it's kind of difficult to excrete iron. Bone marrow transplants, and then bone marrow stimulation, erythropoietin, granulocyte macrophage colony stimulating factor. You don't have that many cells left in your bone marrow, but if you can stimulate the few ones you have to work extra hard, maybe you can kind of offset whatever disability you have. And this slide, don't pay attention to anything here. This is just to remind you that a really common reason for this is the fact that it is secondary to medical drugs that you might have wiped out your bone marrow. All right, so that was the non-hemolytic, just the underproduction, whether or not it's just you don't have enough iron or you don't have enough EPO, or you wiped out all the cells in your bone marrow, all the stem cells. Now let's look at the hemolytic, the red blood cells that are just dying prematurely. And we can divide this into two sections, the intrinsic and the extrinsic. So intrinsic meaning there's something wrong with the red blood cell itself. The red blood cell just sucks. It's unstable and it just dies. And so that is an intrinsic cause. And if you look at all of these, a lot of these are just genetic syndromes, which might cause the red blood cells to be crappy. A lot of times a crappy red blood cell will get taken care of and eliminated by the spleen. Extrinsic is exactly what it sounds like. It's extrinsic. It's autoimmune, so it's an antibody attacking the red blood cell, or it's bumping into barriers in small vessels or large vessels, or you have an infection that kills all your red blood cells. So intrinsic versus extrinsic. Not to confuse, so we have two types of homologous, intrinsic and extrinsic, whether it's due to intrinsic or extrinsic factors, but then there's also two locations of hemolysis. Are they in the vascular, just in the blood vessel? Is the red blood cell just dying? Here's an example of the C5 to C9 complement proteins activating the MAC system, which is going to cause the red blood cell to just lyse right there in the capillary, right there in the artery, or is it going to go ahead and be destroyed in the spleen a little bit more delicately, we might say. So that is the location is another way of characterizing the type of anemia. So we've talked about some of this before, but just to go back into it, if you're a red blood cell, you do not do aerobic respiration, which means you need a way to regenerate you make NADH, but that means you used up all of your NAD plus. So you have to regenerate it. Normally, you regenerate it at the electron transport chain. You don't do that in red blood cell. You don't even have a mitochondria. So instead, you use lactate dehydrogenase to regenerate it, which means we have tons of lactate dehydrogenase in red blood cells. So when they die and they spill their guts everywhere, LDH is going to go up. Similarly, they're going to die and spill their guts. And what are red blood cells if not just large bags of hemoglobin? So they're going to spill their hemoglobin out into the plasma. And some of the hemoglobin gets converted into, the heme gets converted to bilirubin. And sometimes we have this protein called haptoglobin, which just snatches up the free globin monomers. And so if the haptoglobin is binding onto the hemoglobin proteins, that means that our free concentration of haptoglobin goes down. But haptoglobin, as I'm saying here, goes up in inflammation in general. So while it might be sensitive for hemolysis, it is not specific for hemolysis. All right, so we're spilling our guts. We got lots of heme going everywhere. It means we've got lots of bilirubin, specifically indirect, unconjugated. This could cause jaundice. Now, abdominal pain and back pain, the hemoglobin will bind onto and consume nitric oxide. Nitric oxide is a vasodilator. It's a smooth muscle relaxant. And so if you consume all of this, then your muscles are just going to randomly contract. This causes back muscle spasms, which are associated with pain. That also causes abdominal pain, but the abdominal pain might be like extra bad because also splenomegaly is going to be a feature here. You need nitric oxide for the vasodilation of the penis, so erectile dysfunction is going to be a thing. Also, the smooth muscle relaxation and contraction is going to be an important, highly regulated dance for something like peristalsis. So dysphagia, difficulty swallowing is also going to be an issue. There's lots of different types of, maybe not lots, mainly we have cholesterol, gallbladder stones. But you can also, if you have too much bilirubin in the blood, which you would have if you have tons of hemolysis, you can also get what's called a pigment stone, which is really just lots of bilirubin, which accumulates and precipitates. Too much hemoglobin might eventually just get passed into the urine, so hemoglobin or urea. Often, though, a urine dipstick cannot differentiate between myoglobin and hemoglobin. So sometimes it's unclear if it's rhabdomyolysis. You might have to, look at other features like is there jaundice, are they anemic to differentiate these two. And your red blood cells dying, they're spilling out their guts, spilling out their hemoglobin. So we know that the globin things proteins get captured by the haptoglobin, but then the heme gets recycled and then the iron gets evacuated. The iron is going to get grabbed by ferritin. If there's too much ferritin grabbing too much iron, it might clump together and it becomes insoluble. It becomes something called hemosiderin. The hemosiderin can deposit in various joints and tissues, but it can also go into the tubular cells of the kidneys, and eventually, put very scientifically, it can just go pee-pee. Your hemosiderin can be in the urine, hemosiderin So as you can probably imagine, intravascular hemolysis is going to be a little bit messier than extravascular. The spleen is, it's late, and I don't have a great metaphor, but the spleen is ready. Its job is to kill people in a very, precise and delicate way, and so it has a specific mechanism ready for cleanup. Intravascular hemolysis is killing somebody in the street, and then it's maybe the spleen is like a careful assassin that it kills somebody, and then it has all of the plastic to roll them up or something. While the intravascular hemolysis just dies, and then their body's just in the street, and I think I made my point. So we're gonna have more hemoglobinuria, more hemosidenuria for intravascular, less for extravascular. Same that the haptoglobin levels are going to be more diminished in an intravascular versus extravascular hemolysis situation. All right, so just going a little bit more in the spleen. So in the red pulp of the spleen, these red blood cells will eventually just empty, this blood vessel just ends, and they just go into this empty circulation, and they go to this sinusoid area. We might also call this the splenic cords. We might call this the cords of Billy-Roth. But effectively, the red blood cells then have to squeeze into these new capillary beds called sinusoids. And I kind of imagine it like kids doing the limbo. So kids can do the limbo. A young, healthy red blood cell can do the limbo. They can make it through no problem. But an old red blood cell or a defective, crappy red blood cell, I think of like the scene from Midsommar where it's just like, let's just take care of the old people. Let's take care of the old red blood cells that are older than 120 days. That is the job of the spleen. So anybody that has difficulty making it through, that's where these macrophages are going to come in and destroy them. There's just another picture over here. So for the most part, this is old red blood cells, but for, I guess, the purposes of our hemolytic anemia, we can think that there might be a lot of defective red blood cells that are just going to get, sort of, euthanized. So extrinsic causes, autoimmune, microangiopathic, macroangiopathic, small vessels, large vessels, and infections like we talked about. So autoimmune antibodies will bind and they'll typically be removed by the spleen. So remember that the spleen, it's hard to grab onto this frog, but if we put this leash on it, it's easier to grab. The leash is the complement protein C3, which macrophages can grab on more easily. And so commonly this will then be in the spleen or the macrophages can grab onto that antibody C3 and get rid of it. So red blood cells are typically immune from our complement system because they have this CD55, also known as DAF, and CD59, also known as MIRL, which will inhibit complement activation. We see them here, CD55 and CD59. Notice that they are anchored by a GPI, which will come back into play later. Now there's two different types of, so yeah, this is the healthy red blood cell and no hemolysis. And if you're missing these, then you do have hemolysis, which we'll come back to. But there are two types of autoimmune hemolytic anemias, so-called warm and so-called cold. So the warm one's not really warm, but the cold one is cold. So the warm one is just warm in comparison to the reference point of the cold one. So it's really just normal body temperature. It's an IgG antibody on the red blood cell. Sometimes it's idiopathic, sometimes it's caused by lupus, sometimes it's caused by lymphoma, sometimes leukemia. Medications, methyl-dopa and penicillin can precipitate this autoimmune antibody. And the red blood cells will become spherical and they lack a central pallor. So if it's a spherical red blood cell, it just basically cannot do the limbo when it tries to go through the spleen and it gets destroyed. And so the spleen is killing so many red blood cells. It just gets engorged. It's too many red blood cells that it has to kill and deal with. And so the spleen will get enlarged. You might even want to take out the spleen because it's killing so many of your red blood cells. So probably for refractory cases, a splenectomy would be necessary. Remember that if you take out the spleen, you might get Howell-Jolly bodies. A Howell-Jolly body is just a red blood cell with a nucleus. Usually the spleen takes care of those, but nope, not if you don't have a spleen, it doesn't. Alternatively, let's just suppress the immune system with glucocorticoids or immunosuppressants. And maybe these antibodies will stop targeting these red blood cells for no good reason. So if we want to detect these antibodies, we can do what's called a Coombs test, also known as a direct antiglobulin test. So here are my patient red blood cells. Maybe there are antibodies, maybe there are not antibodies. And remember, these are IgG antibodies in the case of warm autoimmune hemolytic anemia. So we will then mix these with anti-IgG. So this anti-IgG over here might go ahead and bind, they might bind to this one and bind to this one. And if that was the scenario, we would have them, they would then all clump together. And we would go, aha, so there must have been, antibodies initially on a red blood cell. If they don't clump together, then this picture is misleading. There was actually no of these black antibodies originally. So a negative Coombs test and a positive Coombs test. So Coombs test is the DAT, direct antiglobulin test, but you can also run an indirect antiglobulin test. So again, in this one, you're taking the patient's red blood cells, which already have the antibodies on them. You're adding the anti-IgG, which binds to IgG Fc regions, and then you look for the agglutination. If there's agglutination, you know that the person has an autoimmune hemolytic anemia. And the question here is just, do they have the hemolytic anemia? Now, in the indirect test, we're not taking the patient's red blood cells, we're just taking their antibodies. And we're actually putting them with dummy red blood cells and the anti-IgG antibody. and I want to see if there's agglutination or not. This is testing for a very similar thing, but also a little bit different. I just now want to see, are there antibodies in the serum, period. Maybe these antibodies actually wouldn't even be interacting with my red blood cells. Maybe I want to see if I want to give you a donation of type A negative blood or something. And I want to see if you have maybe this is my A negative red blood cell. And this is just one thing that I can think of off the top of my head. There might be several reasons you would do this. But in this case, we would see if you have antibodies to the A negative antibody. So this is just the indirect Coombs test, and you're testing the plasma for the antibody rather than the antibody already on the red blood cell. So that was warm. Now we have the cold. The cold is going to be in the extremities. Instead of an IgG antibody, it's an IgM antibody. The IgM, remember, is really good at fixing the complement, specifically because the complement has to be cross-linked so one C1 protein has to bind to two antibodies. Well, that's really easy on the IgM because it's a pentamer. So the IgM is really good at fixing the complement. So it activates C1, which activates a bunch of other stuff, which activates C3. C3 can then activate other things, but it also, again, acts as that handle, that frog leash that we saw earlier. So the IgM, though, does fall off in the torso. Why? Because it's colder in the extremities. That's where they bind. But once you get to the central organs, the IgM falls off. But the C3 stays on for the most part. So if we wanted to run a Coombs test, a direct antiglobulin test, we wouldn't check for the antibodies because the IgM will have fallen off at that point, but we would check to see if the C3 is there. What causes cold? Autoimmune hemolytic anemia, mycoplasma pneumonia, infectious mononucleosis, also known as the Epstein-Barr virus, and then chronic lymphocytic leukemia. The cure for this, just immunosuppressants or just stay warm, really. Probably staying warm is a little bit easier because, again, it's going to be in the peripheries and the extremities where it's cold is going to precipitate this autoimmune reaction. Okay, so this is, I don't really know the name for this, but let's call this MAHA, right? Well, didn't we see another MAHA? Yeah, the other MAHA is microangiopathic hemolytic anemia. And this is macroangiopathic hemolytic anemia. Micro versus macro. The other one was in small blood vessels and capillaries. This is in larger areas, probably most commonly a mechanical heart valve and aortic stenosis. So the red blood cells are just flying past, really quickly, and it's all about running into stiff, hard things. In aortic stenosis, you have a really stiff valve, and if you have a mechanical valve, well, you know what? There's probably some metal or something in there. That's probably pretty hard too. So these stiff walls, running into them is going to cause the red blood cells to, for lack of a better way to put it, they're going to explode, and it's going to cause a hemolytic anemia. So that's the macro. And then we have the micro, which we've talked about previously, idiopathic thrombocytopenia purpura, and then the the ITP, TTP, and then the disseminated intravascular. Again, it's coagulation, but I like to think of it as clotting. Why? Because it's not just coagulation factors, it's clotting. It shows that it's coagulation plus platelets. Platelets are a thing here as well. And so what you have is, so this is, I guess, a normal, healthy capillary. And in this case, you have a little bit of a thrombus. So thrombus, and it doesn't say here, but you know what? There's a thrombus there as well. And they try to run past, and they get sheared off a little bit, and you get these schistocytes. So the schistocytes are going to be very telling for this. And here's a schistocyte, here's a schistocyte, here's a schistocyte. Again, they're trying to run through, and they basically get cut in half or cut in, a quarter of them gets cleaved off. So this would lead to a hemolytic anemia as well. And then lastly, we have malaria and babesia are probably the two major pathogens which could cause a hemolytic anemia. You get rings with babesia, and you also get rings, but they're trophocyte rings with malaria, so slightly different, and stuff that we'll go into a lot more detail on in the bacteria and pathogen parasite section. So that was extrinsic. Let's look at intrinsic. So these are mostly genetic defects of the red blood cells themselves that make them deformed, which often makes the spleen want to take them out of commission. So hereditary spherocytosis. So SP for spherocytosis. You have spherical red blood cells. and it's usually due to defective cytoskeletal proteins. The main one is spectrin. It could be a band protein or it could be ankyrin. Here's my band protein, here's my ankyrin. How does all of this work? I don't know, it doesn't matter. Spectrin, SP is probably the main one. The idea is, so this is important to have the cytoskeletal connect to the membrane is important to give it its nice, biconcave shape. And if you are lacking any of these three proteins, it is going to cause the red blood cell to change its shape to be spherical. And if you have this deformed spherical membrane, you will be taken out in the spleen extravascular hemolysis, because at the cords of Billerroth and the sinusoids of the red pulp of the spleen, you can't do the limbo, and so the red blood cell will get destroyed. Like we saw in Cooley's anemia, which is beta thalassemia major, like we saw in iron deficiencies, we will have higher variability in red blood cell size, which is just to say that the RDW is a little bit higher here than it would be in a wild type healthy cell. Also, the mean corpuscular hemoglobin concentration goes up, but that might be less important. So because they're spherical, there's a reason, there's a purpose to the shape that they have. And so the spherical shape, it might sound good to be spherical, but it's actually much less stable and it's more fragile. So it's more likely to lyse. And something that makes a red blood cell lyse is if you put it in a hypotonic watery solution. Why? Because water will want to rush into to osmosis. And like we can see in this one, too much water rushing in might cause it to swell and explode. Now, most cells will eventually explode if you put them in too hypotonic of a solution, but I guess the idea is that they are more fragile, and so they will lyse more quickly than the other one. So here's our normal situation, sodium chloride concentration. So I'm slowly raising the concentration, and look, this is where my red blood cells should be. This is my red blood cells, and this is my plasma. They're staying strong, and right now they start to die a little bit. Too much, it's too watery, water's rushing in, it's killing them. And then they're spilling their red hemoglobin guts up here. So it's getting more red and more red and more red. And okay, pretty much here it seems like homogeneous, that most of them have died at that point. Okay, what happens in this case, though, is that they're more fragile. I've barely raised the hypotonicity, how watery the solution is at all, but notice in this case, they're already dying. And it's only 0.65. Here, they didn't start to die till 0.5, but again, the point is that they're more fragile. All right, paroxysmal nocturnal hemoglobinuria, PNH. So we saw this picture earlier. CD55 and CD59 say, hey, cool it complement, right? The C3 can come in and it's not allowed to activate the complement system, so there's no hemolysis. Good. We don't want hemolysis on our own red blood cells. But sometimes people just, over the course of their life, they acquire mutation in the hematopoietic stem cells, specifically the gene that codes for the GPI anchor, which is necessary to bind the protein to the membrane. And so if I don't have this, I lose these inhibitory complement proteins. And so then the complements just go nuts, complement activation, and they kill all of these red blood cells. It might also affect platelets and white blood cells too, so it actually might be a pancytopenia. One way you can diagnose this is through a flow cytometry. So a flow cytometry is I would put like a fluorescent antibody that would bind here, and so it's going to fluoresce red right there. And so I would put this in a machine and it shows red fluorescence, and that tells me, okay, it's red fluorescence. It must mean that my fluorescent antibody bound to CD59, and here I would have no fluorescence, and that must tell me that I must be missing something here because I didn't have an antibody that fluoresced that was bound to my cell. So paroxysmal just means that it's intermittent. It comes and goes. Now it comes a little bit more at night. So this is actually debatable, but let's just go ahead and say it comes more at night. The idea here is that at night you're hypoventilating, and this shallow breathing might increase the amount of CO2. So, you're not breathing out as much, so the CO2 goes up. And, we all learned in undergraduate intro chemistry that Le Chatelier says if that goes up, this is an equilibrium. So it's going to push this to the right. So the hemoglobin concentration goes, not the hemoglobin, the hydronium H plus concentration goes up. So this lowering of the pH causes this respiratory acidosis, is actually going to stimulate the complement system, which is why this might be worse at night. The red blood cells lysing, as we see here, means they're spilling their guts, as we can see here. And this is going to, it's intravascular hemolysis, which we said is the worst one. That free plasma hemoglobin is particularly thrombogenic. So you're getting this specifically because we have the hemoglobin, this is going to be released into the bloodstream. This might cause jaundice, and if we have too much of this, some of it might be going into the urine. On top of this, though, why I got confused a little bit is this should also say thrombus. So these are two separate things. You're going to have hemoglobin in the urine, and then you're also going to have thrombus. So the thrombus here is because the plasma hemoglobin is also thrombogenic. On top of that, we said that this might be pancytopenia because the same thing, the CD55 and CD59 that are working for the red blood cell might also work for the platelets. So platelets will be destroyed as well. When the platelets are destroyed, the alpha and dense granules get released, and these secretions are going to activate the GP2 and GP3, causing platelet aggregation, which might just form a thrombus. So eculizumab, which I'm sure I'm mispronouncing, is going to be an anti-complement protein 5. So if we think about this, complement protein 5 to 9 are responsible for the MAC complex, which causes the intravascular hemolysis, the osmosis, the flowing in of water in the red blood cell. But remember, we still have C3 bound. So the MAC over here is inhibited, but I still have C3. So these will still go to the spleen, and then remember, this is the frog with the leash on it. The leash is the C3. The macrophages in the spleen at the cords of biliary still might grab onto these red blood cells and destroy them. So we still might have some extravascular. So it works, but doesn't work perfectly. G6PD, we saw this in the biochem thing. This is X-linked. Often it's in people of African, Middle Eastern, and Mediterranean descent. And like we see in sickle cell, like we see in thalassemias, this might have a protective effect against malaria. So glucose can obviously go down to become pyruvate. Glucose, phosphate can go ahead and become glycogen, but it can also go through the pentose phosphate pathway to make, among other things, NADPH. NADPH can help make glutathione. Glutathione reduces reactive oxygen species. So if I have a deficiency of this, that means I'm going to have more reactive oxygen species, which might cause my red blood cells to become sick and to die. Now, this will become exacerbated and triggered, extra reactive oxygen species if I have infections, if I'm taking certain drugs like sulfa drugs or any sort of antimalarial drugs, anything that ends in quin. Primaquin is our example here, and favabeans, which made me think of Hannibal Lecter. So characteristic of this, this comes in other cells, but in other conditions, but it's really, I would say it's mostly in G6PD, is our, let's start with Heinz bodies. So we might have these Heinz bodies here. And the Heinz body with this little basophilic remnant on the side, when this gets into the spleen, the macrophages will try, because it's on the periphery, they will try to take they won't destroy the entire cell. They might just destroy this little bit right there. And so now, as a result of the Heinz bodies, we get these bite cells. And it's just a little bite has been taken out of the red blood cell by the macrophages. And again, this is the deficient enzyme here. So pyruvate kinase deficiency, red blood cells rely on glycolysis for energy. And if you don't have ATP, you can't generate. So pyruvate kinase is the last enzyme in glycolysis. So you're going to have insufficient energy production. And if you don't have enough energy, you can't maintain your membrane. And if you don't have a membrane, you cannot do the limbo through the cords of biliary, which means the spleen is going to eat you up, which is extravascular hemolysis. It's really common to be seen in newborns. Sickle cell anemia. So again, protective against malaria. People of African and Middle Eastern descent. Vaso-occlusions cause episodes of extreme pain. Could cause stroke due to difficulty for the sickled cells to get through the smaller microvasculature. Splenomegaly is the spleen is just trying to, all of these sickled red blood cells have a hard time getting through the cords of biliary. And actually, this can cause destruction of the spleen because it gets just too large. Severe fatigue because you're not getting oxygen delivery. And you can treat this with hydroxyurea because it's the hemoglobin A that's defective. But if you could make fetal hemoglobin. Excuse me, not hemoglobin. I spoke correctly. Hemoglobin A is defective because we have a deficient beta globin gene, but the hemoglobin F actually still works quite well. The problem is that we just have like 0.1% production of hemoglobin F, but hydroxyurea can increase the concentration so that it actually might be able to, deliver a little bit more of the load, and our oxygen delivery can be closer to normal. So one allele, the heterozygote advantage, might be protective against sickle cell, and you might be, normal-ish because you've got some normal red blood cells and some sickle ones, and it kind of maybe balances out. The homozygotes would be obviously the particularly bad scenario where you have severe sickling. So hemoglobin A, so this is specifically the beta globin gene, our sixth amino acid. The glutamate is converted to a valine. Valine is hydrophobic, and all of these hydrophobic things stick together, hence the sickling. And at low oxygen and acidic conditions is where the sickle cells will precipitate together and aggregate. So at low oxygen and acidic conditions, this disease is going to be worse. B19 parvovirus, so this is going to get into the bone marrow and replicate inside of, so this is our red blood cell precursor. This is going to get inside and replicate there. So normal people, maybe we'll get a little sick, often kids, like mild anemia, but nothing too bad. Because we don't, we're having a little bit of hard time with erythropoiesis, but, our red blood cells last for 120 days and we're fine. We have plenty of red blood cells. But if somebody has a chronic hemolysis condition, if they have sickle cell, hereditary spherocytosis, any of the thalassemias, especially thalassemia majors, G6PD, especially if you have one of these triggers, you're eating a lot of fava beans or paroxysmal nocturnal hemoglobinuria. These guys, their red blood cells are dying all the time. They need every bit of erythropoiesis they can get. So if they have a B19 parvovirus infection, they are really screwed. They're in bad shape, and this can lead to an aplastic crisis, which is not good. All right, last one.